Boy, it's terrible to have to follow such a smart guy like Sage Wiener. You know? I mean, I wouldn't know physiology if it bit me in the backside. But, okay, so don't expect any, myocytes or anything in my lecture. Right, so I want to talk about cardiovascular emergencies in the elderly. And why? Why am I going to waste 45 minutes of your time on this? So cardiovascular disease is the #1 killer in the US. It's much more common and more deadly in the elderly. And the prognosis in the elderly of things like acute MI is much, much worse. Right? And then the elderly population is rapidly increasing. Anybody know what we call that phenomenon from my other famous lectures? What do we call that phenomenon? Graying of America, right, you guys? Okay. So, for example, right now there are 35 million people over 65. By 2030, there'll be 70 million of us coming after you millennials, right? Including by then we'll have Silverberg in our group, you know? So, and you're going to then see even more and more cardiovascular disease because it's much more common in the elderly. Okay, so what are our goals and objectives here? So we want to learn about some principles of geriatric emergency medicine and how can we apply them to cardiovascular emergencies. We want to talk about the differences between the old versus the young, other than the fact that we are smarter and better looking than you guys. And we're going to apply those principles to 5 important elderly cardiovascular diseases. Okay, so my 4 GEM principles. Because of a lot of comorbidities in the elderly, diagnosis and treatment is much more difficult than it is in younger people. Diseases often present atypically, so it's harder to make the diagnosis. So you have to be much more careful to try to diagnose this. Also, there's less reserve in the elderly, so that means they're sicker and they decompensate more rapidly. So if you miss the boat, you may not be able to pull them out of the water and keep them from drowning. Okay? And then there's an increased risk of ADRs, adverse drug reactions, in the elderly. However, especially when it comes to cardiovascular emergencies, the elderly have so much of a worse prognosis that even though they also have a much more increased risk of adverse reactions to the drugs we use, like thrombolytics, you still gain more by using them in the elderly. Much more than if you didn't use them. Okay, so what are the 5 important diseases we're going to try to cover until Dr. Willis cuts me off? Okay. Acute coronary syndrome, CHF, dysrhythmias, aortic dissection, and AAA. So what are our goals of care here in these bad illnesses? Well, just remember that the elderly are sicker and they have less reserve and they're going to decompensate more rapidly. They're going to have sometimes delays in diagnosis and treatment. And in one study, for example, that even though, yes, the elderly was sicker and they decompensated more rapidly, the thing that caused more M&M was that the diagnosis wasn't made readily and they didn't get aggressive enough treatment. And that was in this particular study, about 25% of the patients who died felt were salvageable if they had been diagnosed better and were treated more aggressively, particularly with reperfusion. Okay? So, very important, even though they have increased M&M, a lot of them are salvageable. So early accurate diagnosis and aggressive treatment is important in them, actually probably more important than it is in younger people. Okay, so let's talk a little bit about acute coronary syndrome. So it's the #1 cause of death in the elderly. About 1 million people all over in all age groups a year die of acute coronary syndrome. Consists of unstable angina and STEMIs. And in the elderly, NSTEMI is the most common of these three. Age is an independent risk factor for both having the disease and for dying. And the evaluation and treatment is going to be very similar, but there are some special things we'll talk about that you need to watch out for. And then again, the presentation, like in most illnesses in the elderly, is often very atypical. Okay, so what are some atypical presentations that you might find in the elderly? So they may have atypical chest pain as far as the severity of the chest pain, how they describe it, and where it's even located. They may not present as chest pain being the main thing, but they may present with dyspnea, or congestive heart failure, or diaphoresis, or GI symptoms. My dad, when he had his MI, for weeks prior to the MI, he was getting unstable angina, and both me and the physician on Avenue P in Bensonhurst misdiagnosed him as just indigestion. So you can miss these things. Fatigue, weakness, syncope, dysrhythmias, CVAs, altered mental status, they all can be a presentation of acute coronary syndrome in the elderly. So you have to be careful. Any bad thing, you got to make sure they're not having an acute ischemic event. How about your exam? Okay, so obviously you start with vital signs, because vital signs are vital, and they tell you how sick the patient is, and especially in the elderly, who are prone to decompensate more, you want to make sure they're stable. If you find evidence of CHF on the exam with an acute coronary syndrome, they have a worse prognosis. Okay? You want to listen for murmurs, because they may have blown out their mitral valve. They may have ischemia of a papillary muscle, and that may be causing CHF, and they actually may need surgery for it. And then why it's very useful on the exam is you might find other causes of chest pain. For example, pneumothorax or pneumonia. Okay, so what about the EKG in the elderly? Right? It's the single most important test that you can do for an elderly person that you suspect might be having an acute coronary syndrome. Okay? The standard is that you should try to get that EKG within 10 minutes. Right? And it should be immediately available to you. Good luck with that. Right? Even if it's done. And your threshold in the elderly should be lower to get. I know sometimes people say, well, what happens if I get it and it's abnormal and now I'm stuck? Well, maybe you should be stuck, because it might be something real. And you want to err on the side of overdoing the EKGs in elderly patients who you think might have a coronary syndrome. Okay? And then what about the sensitivity and specificity? Is this 100%? No. So they've done some studies where if you're very, you're very scientific, you're a Rich Sinner, for example, and you're very scientific. If you say, I'm only going to count ST elevations or real SST depressions, right, that have to be a millimeter up or a millimeter down, right, then your sensitivity is only about 60%, although your specificity is about 95%. If you want to be more careful and you include things like T-wave inversions, changes in a territory, like 2, 3, and F, or 1 and L, V4, V5, V6, right? New Q waves. If you do that, then your specificity falls down, but your sensitivity increases. If you include all those things, your sensitivity goes up to over 90%, although your specificity in some studies goes down to about 30%. Yeah?
So, in terms of like when we're speaking about elderly, is this kind of like extreme elderly 85, or is it more like 65, 60 kind of?
So I'm starting at about 60, 65, but as you go up, it becomes harder to diagnose in the sense that they're more atypical, that they also may have more underlying problems in their EKGs, for example, that make them harder to read. Over the years, they have gotten a left bundle or second-degree block or something, okay? So the older there are, the more likely they have acute coronary syndrome, and the more likely their prognosis is worse, and the more likely you may miss it unless you throw a wide net. They did a study in patients who were 80 years old, compare them to patients who were like 40 years old. For patients who were 40 years old, came in with chest pain, less than said, about 7% or less, had an acute coronary syndrome. In patients over 80 who came in with chest pain, about 71% had some kind of acute coronary syndrome. And the older you are, the more impressive that gets. Okay? So I just wanted to show this one. Yeah, great. It's working. This is just how a STEMI evolves, right? First, you start to get maybe tombstones and impressive ST elevation, hyperacute Ts. Then it starts to cove over. Maybe you're starting to develop a Q wave. Then definitely coves over. T waves flip. ST elevations come down. And then you have probably a permanent Q wave. And it may or may not come back, the T wave. Okay? And that's going to be, when you talk about STEMIs, you're going to see these changes in the leads that reflect that territory. So if it's an inferior MI, you're going to see those changes in 2, 3, and F. Whereas you'll see reciprocal changes in 1 and L, meaning ST depression. Oh, it's anterior lateral MI, you'll see changes in 1 and L before V5, V6 like this. And then in 2, 3, and F, you might see ST depressions. Okay, so I need some help here. I'm an old Jewish man, I'm tired. I did a shift yesterday. So, and then I had a banquet. So, given all that, I need your help. So, someone help me here. So we have a 75-year-old man, comes in mostly with a little bit of chest discomfort, but shortness of breath, right? Yeah, not an MI, doesn't have terrible crushing chest pain, no elephant on his chest, right? Someone want to interpret this EKG for me? You want to do that? Anybody? Bonnie, come on, you were so nice to me yesterday. Why don't you do this?
You have ST elevations, V2 to V5, with the typical changes to
So ST elevations.
and 1, and AVL.
So,
Almost everywhere.
right, so this guy with a little shortness of breath has a huge anterior MI, right? Has the classical. He has the classical STEMI in these leads and in most of his anterior leads, right? All the way out, both in the septal and then in the lateral. And one other thing I want you to notice, though, is these reciprocal depressions. There are studies to show that if you have reciprocal depressions along with elevations, those elevations aren't false. They're not from LVH. They're not from a left bundle. They're not, benign early repole. You see that, that's like 95% sensitivity and specificity that this is a real acute MI. You're not always going to see it depending on what leads are affected. But if you see that, you know that's real. Call Dr. Marmer. Okay. So here's another case. Bloomberg, you're one of my friends. You sometimes bring me a free Mountain Dew. You know, so what do you think about this 75-year-old man with chest discomfort for 4 hours who's known to have a left bundle? Because you looked up his last visit to the ER last year with some chest discomfort, and they noticed on it that he had a left bundle, right? What do you think about that? What do you think? What do you think?
So I would go on the internet, I would look up Scarbosa's criteria, because I can't remember it in my life or anyone else has a pen on this. But I see a left bundle pattern, I see ST depressions in 2-3 and ABF. And I'm concerned about the CKG. I want to compare it and apply Scarbosa.
Okay. So I tell you, very, very good. You're not sure of something? Look it up. Right? No one says you have to be as smart as Rich Sinnerd and know everything by heart, or know the sensitivities and specificity of everything. But so that's good. I like that. Punting it. One thing that bothers me here. So let's go forward one step. Right? Here's quote unquote a normal left bundle. We have the classical mountains in the left leads. Right? I like to call them mountains. And we name it a left bundle because mountains are majestic. So the left leads in someone is 1 and L and V5, V6. That's where you're going to see, look at 1 and L, those big mountains, right? And in a normal left bundle, you should have what's called discordance. Meaning that if the repolarization of the QRS is up, the ST should be down. That's what a normal left bundle should look like. So, for example, this is up, that's down. That's what a normal left bundle looks like, right? A lot of old people have left bundle, and you may not see the MI there, but there may be some clues. Or here, the repolarization of the QRS is mainly going down, so the ST should be up. Yeah, oh, is that an anterior wall MI? No, that's part of the left bundle, right? So you should have discordance. Let's look at something. Well, wow, this should have been down, but I'm seeing elevations here. And there are also some reciprocal depressions, as you pointed out. But look at that elevation. This is concordant. So one of Sgarbosa's criteria is that in leads that should have ST depressions, instead you get ST elevation of 1 millimeter or more. That's really very specific. The Sgarbosa criteria are not very sensitive, but they're very specific. Particularly, that's the most specific. Okay? The other one is that in leads that should be up like this, if you see depressions in those leads, that's also worth 3 points. Anything 3 points or more in his criteria is considered very specific for or suspicious for having an MI. Right? Here you don't see that, but you do see his biggest criteria. And the third one is that that in these leads, V1 to V2 and V3, that normally in a left bundle you do get some ST elevation. If the ST elevation is more than 5, you have to be suspicious that there's an MI in there. That's the least specific and the least sensitive of his criteria. In fact, it's only worth 2 points. So it by itself, unless you have an old EKG to compare and say, hey, this is really different, that is not enough to make the diagnosis. And people will talk about the modified Sgarbosa's criteria and you measure things. Don't worry about that for now. I'm not smart enough to teach you about that. So But again, look, this was his old left bundle. So old EKGs help, right? You can get an old one with old people who may have really abnormal EKGs and compare it. It helps you. One study showed that, as we know, that when you look at money given out for malpractice, for emergencies, we know that missed MIs is the biggest amount, right? Because these executives go home who are type A personalities, and you miss it and they go home and die, and they were making $1 million a year and they have 3 small kids, and the jury gives them, you know, $100 million award or something. So, in one study in the elderly, 25% of missed MIs were because of misreading the EKG. So you want to be very careful. And the elderly, like I said, are harder to read their EKG. Okay, I think I got to speed up. Okay, so 80-year-old woman with substernal discomfort and shortness of breath for 3 hours with an episode of syncope has no old EKG available to you. So, one of my favorites, Jardine. He always helped me out. He even drew blood for me that no one else could get yesterday. Right? So why don't you help out an old man now? What do you think? What do you think might be going on here? So what do you think? What bothers you? What leads bother you? What looks bad to you? Remember, we're not going just by STEMIs, because remember I said, if you go just by ST elevation, your sensitivity is only 60%, right? So look for other things too. Oh, okay. So there's T-wave inversions here, right? Especially in these leads. And they may come like this, or they may go real down and deep. But those are ischemic T's in my mind, right? That's from ischemia. Occasionally they may be from things like subarachnoid, but for your ideas, no, that's ischemic change, right? And you know what that this is a type of, that this might be called? This is a Wellens dip, one of the types of Wellens dip, right? The more common type is that it's going to kind of come up and cove over. But also, some people consider it also these deep T waves in these 2 leads, in V3 and V4 particularly. But what a Wellens dip means is that there is involvement of the left anterior descendant. And these people are very prone to get deadly arrhythmias, especially with stress, okay? So, this guy may have had a run of VTAC or something. That's why he's syncopized. And if you put him on and if you misread this and you put him on a stress test, he may die on you with the stress test. Okay. So anyway, for me, this is just as bad. Yeah, I hate the one that coves over, the real, what we all call the Wellens dip. But if I see this too, I'm not messing with this in these 2 leads. I'm not messing with them. That guy gets admitted. That guy gets capped. Okay. Okay. Well, I like torturing you guys. That's why I may not finish this lecture. So much fun. Okay. So now, true case. 78-year-old man with substernal chest pain for 2 hours. EMS gives him a nitro. And he now has a BP of 77/50. His pulse is 68, so he's not hypotensive because he's bradycardic, which is something you might see with inferior wall MIs and things, right? He has JVD, but his chest is clear, and his heart sounds normal. He doesn't blow his papillary muscle or blow his ventricle septum or whatever. But what do you think? What do you think? Well, here's one of my favorite advisees right here. Always helps me out. right? So, what do you think, Susan? Help me out here. What do you think is going on? Right? Just give me the important findings here.
He has a clear wall MI.
Okay, very good. So he has an inferior wall MI. Look at these elevations in 2, 3, and F. Look at these reciprocal depressions in 1 and L. We know that's acute. This isn't old stuff, right? So I agree. What else might bother you here? Both on the EKG and by the history that might make you want to do something else. What do you think?
Well, you're not supposed to get nitro if it's inferior because they're preload dependent. So.
Okay, if he has what? What? Especially look here. He has elevations in 2, 3, and F. But look how big it is in 3 compared to 2. What also might that be a clue to? Right? And especially, really the clue is that he did get hypotensive with nitro, and he does have distended neck veins despite clear lungs. What other tests might you want?
So I'm really thinking like it's right ventricle, so I want to do like either right-sided or even posterior.
Right, let's do right-sided leads, because what we're worried about is what? Not just an inferior MI, but what goes sometimes with an inferior MI? A right ventricular infarct, right? So let's do this. Leave him on his limb leads, but V1, V2, and then we go V3R, V4R, V5R, V6R, right? Those are how you do a right-sided lead. So let's see what happens there. Wow. What do you think now, Susan? What do you think? What do you see in V4R, V5R, and V6R?
That's right ventricle.
Yeah, look at those ST elevations. He has a right ventricular infarct. And this is a guy you don't want to give things that decrease preload. And what would you do to get his pressure up?
Definitely fluids.
Fluid, right? Despite the elevated neck veins, he needs fluid to help fill that injured right ventricle so it can function a little better. So you're going to give him a bolus of fluid despite the fact he has an MI, right? So knowing this, you saved his life. Okay? All right. So this is a 70-year-old woman with a history of stable angina. We're not going to finish, but I'm okay. You just tell me when to stop. 70-year-old woman with a history of stable angina and CHF now has worsening chest discomfort and shortness of breath for the past 2 days. What bothers you here? Okay? So here's somebody who I torture every Friday, right? Andy. Right? I torture every Friday. You have to sit next to me and make you do my procedures. Right? So you can help me again. What do you see here? What bothers you here? Okay, look at these ST depressions. Here, and here, and here, 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 all over the place. Right? And look especially in these leads. Is there any place where you have an elevation? In AVR. And even though people poo-poo about AVR, you see an elevation in AVR with reciprocal depressions elsewhere. You've got to worry there might be an MI. But a minimum of this is what? A minimum you would say this might be an NSTEMI or severe unstable angina. This is someone you jump on. This is not someone you admit for observation tele. Right? This is someone you don't wait to call cardiology to wait for the enzymes. This is someone that gets pushed. And in an elderly person like this is someone that you're going to push them, even though it's not a STEMI, to go to the cath lab. This is very impressive. Very impressive. This much depression in almost every lead. Okay, so what about cardiac enzymes? Okay? So, I'm going to skip those because we're running out of time. And anyone could, write an order for cardiac enzymes and stuff. And actually, a great article was sent out by D'Souza. I don't know if, everything D'Souza sends out I read because I like being D'Souza. and I trust him. And so he recently sent out a very, very good article on troponins. I don't know if anybody other than me read it, but very good article. Okay, so I'm not going to discuss them. Management. Treat as aggressively as you would young people, because even though they may more likely have side effects, their prognosis, if you're not aggressive, is worse. So it's trade-off. It's always risk-benefit with everything. Okay? And what is your management going to consist of? Well, you're going to use anti-ischemic RX, right? Like they're having pain nitro, antiplatelets, aspirin, and if you're really impressed, Plavix, or one of the other antiplatelets, anticoagulation, right? Either heparin or Lovenox. And then very important, both with STEMIs, but even with a bad non-STEMI, with continued ongoing pain, is to reperfuse, okay? And you want to reperfuse aggressively. There are studies to show that doing it in the cath lab is better for elderly. If you can do it in 90 minutes, right? That's our goal. If you can't do it in 90 minutes, and there's no absolute contraindication, then you can do thrombolysis. And you should. When fibrinolytics first came out, and I remember that well, because we didn't have a cath lab at Lincoln and we were at the mercy of the Bellevue cardiology fellows who often would bust our chops. We did a lot of thrombolysis at Lincoln. And they first came out, 75 was the cutoff. They were above 75, you didn't do it. That got thrown out in the garbage because studies show that, yes, more likely to have a side effect like a bleed from the thrombolytic if you were older, more than 75. But when they looked at the studies, and they studied this, they actually decreased mortality overall with it. So there's no age limit, right? No age limit. So if I come to your ER, I'm 60, almost 69 now, I come to the ER in 20 years, looking as good as I always look, see? And I have a STEMI, and I'm stuck in the county, and none of you guys say, I'm not going to push Gernsheimer across the street. Or, you know, when the ambulance guy says, I ain't coming for that old guy, 99. Then you can give me a thrombolytic, and I'll be okay with it. There's no absolute contraindication. Okay? So, who's going to help me here? There is a guy I like. Surlis. Read that for me. What do you think is happening?
I'm a little sick, so I can't talk very loud. I'm a little sick, so I can't talk very loud.
Okay, you want me to call on someone else? So how about the person next to you?